Good afternoon and welcome to the Maternal Infant Health Series with Wayside Recovery Center. We are going to allow people to join us. We will take about a couple of minutes to allow everyone from around the country to join us for this exciting presentation this afternoon, Intergenerational Trauma in Maternal and Infant Health for BIPOC women, a very important conversation. We would love to see the student nurses are in the house. Janelle, welcome, welcome. I hope you will share with your colleagues. Shelley, thank you for joining us for this valuable time and conversation. I am so excited. All right, our time is valuable and we want to use it well. We are going to start our presentation today with Dr. West-Olatunji. My name is Nicole Fernandez. I am with Wayside Recovery Center, located in Minneapolis, Minnesota. I am here with my colleague, Zora Darcourt, and we are happy to help and support in this very important session. Our agenda for today, I will share a brief introduction to Wayside Recovery Center. I will introduce our speaker. We will hear from her in this wonderful presentation. And then at the end, we will have time for questions, approximately about 10 minutes. And then we will close and share information about the next cohort in the series. A little bit about Wayside Recovery Center. Wayside Recovery Center provides gender-specific case management and care with understanding the needs. The important needs is critical to optimizing prevention and treatment. Wayside has been in existence for over 60 years, and we specialize in empowering women and breaking generational cycles of substance abuse. We are a CCBHC, which is a federally certified community behavioral health clinic. Wayside now provides services to address the whole health that are more affordable and more accessible. Wayside Recovery Center is hosting this Project Echo series in partnership with Minnesota Department of Human Services, focusing on reducing maternal and infant health disparities. This grant is also in funding and in connection with the SOAR grants provided by SAMHSA. We would like to also share that we will be sharing a little more information regarding disclosures in the chat, as well as the upcoming series and any additional language and information regarding this presentation. Now, without further ado, I'm going to take time to introduce Dr. West-Olatunji, and then she will follow me and begin the talk. Dr. West-Olatunji is the Melba Fortune Martinez Endowed Professor in the Counselor Education Program and Director of the Center for Traumatic Stress Research at Xavier University of Louisiana. She has received numerous awards from national organizations and has been recognized as a fellow in the American Counseling Association. Nationally, Dr. West-Olatunji has initiated several clinical research projects that focus on traumatic stress and systematic oppression. Her publications include 3 co-authored books, numerous book chapters, and over 50 articles in peer-reviewed journals. Dr. West-Olatunji has delivered research papers throughout Asia, Africa, Europe, and the Americas. Without further ado, and with great pleasure, I introduce you to Dr. West-Olatunji. Thank you so much.
Thank you, Nicole. Thank you so much for inviting me and my team into this space. The work that you're doing is so important, and I feel honored that you would even ask me to join this group of scholars and practitioners who are talking about these topics that affect Black, Indigenous, and women of color. I have with me today Dr. Lauren Barriell, and she is a native of New Orleans. She's graduated from Howard University in Washington, D.C., where she earned a BA in broadcast journalism, and then went on to earn her MD from LSU, Louisiana State University Medical School. Dr. Barriell completed her residency in internal medicine at New York University. She's provided care to survivors of 9/11 and also post-Hurricane Katrina survivors in the Gulf Coast area. Dr. Lauren Barriell has worked as a senior medical officer with the Schumacher Group, where she's influenced policy change at the Centers for Medicare and Medicaid. Having practiced medicine in a variety of settings, Dr. Barriell currently works as a part-time hospitalist at New Orleans East Hospital and as the physician advisor for West Jefferson Medical Center, providing oversight of the insurance appeals process. In addition to her work as a physician, she is currently pursuing a master's degree in clinical mental health counseling at Xavier University of Louisiana. She serves as a graduate assistant, I should say my graduate assistant at Xavier in my Center for Traumatic Stress Research. So we welcome her to being a colleague. She's both a graduate assistant, but also a colleague of mine. She brings a wealth of experience to the work that we do, and she's now integrating an understanding of clinical mental health counseling into her previous skill set. So we welcome her. I am going to share my screen and try to get us started here with some information. And so again, this topic is intergenerational trauma and maternal and infant health for Black, Indigenous, and women of color. You've probably seen the learning objectives already before you even, when you were registering for this. And so I'd just like to reiterate those. We are hoping that you will increase your self-awareness about biases toward culturally and socially marginalized patients, that you will enhance your knowledge about systemic oppression and intergenerational trauma, and that you'll be able to further identify specific social justice and advocacy interventions to minimize the impact of intergenerational trauma on Black, Indigenous, and mothers of color in particular. And so let us get started.
Thank you so much for that wonderful introduction, Dr. West-Olatunji. Good afternoon, everyone. So we will begin with the status of maternal health and well-being in BIPOC women. We've all heard stories about racism, particularly in healthcare, stories of women like Henrietta Lacks, or the many women who suffered for the benefit of obstetrics and gynecology at Johns Hopkins. Many women of color have experiences that they believe negatively impact their infants. Things like stressful interventions with all levels of staff, including physicians, nurses, ancillary staff, and administrators, disrespect, overt racism and discrimination, paternalistic attitudes from their physicians, lack of communication with failure to provide information regarding diagnostic information, lack of discourse, being unheard, and inconsistent social support, which we all know improves pregnancy outcomes. While infant mortality has decreased globally, preterm birth and infant mortality has remained disproportionately high in people of color, especially in Black women. Black babies have 3 times the risk of infant mortality. And to be clear, infant mortality is considered death from any cause within the first year of life. But preterm birth is the leading cause, followed by birth defects, injury, sudden infant death syndrome, and pregnancy complications, but not necessarily in that order. Next slide. Over the last several decades, the US has focused on decreasing infant mortality rates. And the question came to me, if interventions are applied across the board, what accounts for the disproportionately higher rates of preterm birth and infant mortality in communities of color? Recent research has shown that there may be factors other than physical that are impacting our communities of color. One idea that has come across in recent years is the idea of intergenerational trauma. But what is intergenerational trauma? The definition of intergenerational trauma is derived from a study that investigated the outcomes of Holocaust survivors' children. And what it found was that there was a very particular set of features that resulted. And it wasn't specific to the children of Holocaust victims. It also occurred in families of World War II and Vietnam veterans, in individuals and groups who lived under repressive regimes. They were plagued by things like domestic violence, crime, and next slide, issues with depression, sadness, irritability, sleep disturbances, diminished interest in pleasurable activities, anxiety, which is specifically designed as anticipation of a future threat, which is to be distinguished from fear, which is the presence of an imminent threat. There's also been noted to be, especially in Indigenous peoples, suicidal ideation and behavior, substance abuse, and violence. Now, the majority culture would have you believe that this is the result of a genetic defect or moral failing, because most studies are deficit-oriented, meaning they are investigating a subsegment of the population that has been marginalized, when what is really happening is that the groups of people are living in an environment that is oppressive. So it is the environment that is the problem and not the people themselves. These things occur when crowded conditions and people lack access to basic human needs such as food, water, clothing, and a safe environment. People are not fighting for the sake of fighting, they are fighting to survive. Next slide. So it's important to focus on how the word trauma is defined. Mental health literature define trauma as the result of attempting to create a definition of PTSD, and so in other stress-related disorders. It is the trauma actually is the result of the events experienced by the person that result from the event and occur in a past time. Intergenerational trauma is trauma that has been perceived over generations of time and are cumulative in effect and are not directly experienced. So I, as the descendant of enslaved peoples, have the benefit of the narrative of my ancestors, but I personally have not experienced slavery itself. And systemic oppression as transgenerational trauma can also not be included in the classical definition of trauma because there is no direct potential threat. It is not physically dangerous. So how someone may experience systemic oppression is not necessarily a threat to their health or well-being at that point in time. One might experience this in the following way. Say you're a young woman and you have a headache and you go to the emergency room or to your physician, and your physician tells you, okay, well, I'm not giving you medication for pain because he has this very stereotypical opinion of you as a drug seeking. He thinks you are exhibiting drug seeking behavior, and thus you are not allowed to access the services that you need to take care of your health condition. Next slide, please. Racism and historical trauma. So one of the things that's important to note is that when people experience trauma, how they deal with it and the outcomes are directly related to how they are situated in society prior to the event. Poor people and elderly people may not have the financial resources to be able to access services that they need. They are consumed with the activities of daily living, obtaining food and shelter and everything. All their resources are directed at the actions involved in simply surviving. So they do not have the financial resources to do that. Mentally and physically impaired people do not have the cognitive capacity or the physical wherewithal to advocate for themselves. And so what we find happening is that people who are aggregated in small sections of the geography experience a disproportionately large percentage of traumatic events and experiences, and they do not have the resources to combat those things. And this is, of course, based upon the institutionalized and historical biases in society. So, oops, hang on just one second. So the lack of access that marginalized people experience has a deleterious effect on their psyche over time. Number one, they lack access to resources. And number two, they lack the power to change the institutions that control the resources. One of the ways that we see this is historically, most of the research done in counseling and therapy has been done on white middle-class participants in society. And they have failed to do thoughtful, substantive research on those same members in society, that same segment in the Black population. All of it has been deficit-oriented, focusing on the negatives and the ills of society. And so we don't really have a good idea of what it's like to be a mentally healthy African-American or person of color in this country. All of the diagnoses are based on the models of normacy for middle-class whites. And so oftentimes I have patients come to me and say, hey, doctor, is this normal? And oftentimes I'll tell them, well, it's normal for you. And I have noticed, however, over the last maybe 10 to 15 years, when I'm looking at lab work, there will include ranges for white people and for Black people. And I think that is important to note, because we are making moves in the right direction, but we need to do a little bit more. So systemic oppression correlates to traumatic stress. And remember how we talked, I talked of the definition of trauma. Now we want to say that traumatic stress is different from trauma because, of course, it is the anticipation of a future event, whereas trauma relates to a past event. And what we find is that over time, history over and over and over again has exerted this systemic oppression on people of color. We know from recent events that that systemic oppression has deleterious effects on both physical and mental health. And there was a long-term study called the ACE study, which looked at adverse childhood experiences, and it showed over time that those physical effects that experienced when you were a child were now experienced as disease when you're an adult. This has been shown in multiple different studies. And when it is chronic and transgenerational, it has an additive effect. So we go to, yeah. So remember, we talked about trauma that is experienced intergenerationally. You don't necessarily need to have a direct exposure to the event because we're far removed from slavery, but we are still experiencing that very same stress because of the intergenerational nature. We talked about the definition of traumatic stress as it was derived from the Jewish Holocaust survivors study, and that how it's been shown in multiple different groups of people over time, and what that looks like in person. So you'll be able to recognize it when you see it. And it may include depression and anxiety, suicidal ideation and behaviors, substance abuse, and violence. So health and education disparities, and Dr. West-Olatunji is going to talk a little bit more about the education disparities. But I can personally say from experience, 20 years worth of working in the medical industrial complex, we'll call it, that people of color experience a disproportionately higher rate of physical ailments, including diabetes, high blood pressure, COPD. And some of these things may be the result of childhood experiences, but I think also there's a large part of the traumatic stress that results from systemic oppression and intergenerational trauma. So we need to take all those things into consideration moving forward. And we're going to learn about some things that we can do to recognize intergenerational trauma and what we can do to help change it.
So now that we've had an opportunity to hear these definitions that may or may not be new to you, one of the things that I've noticed in engaging in interdisciplinary research, right now I'm working with the College of Pharmacy at my university, and I'm working with pharmacy educators. And, we're talking about COVID and COVID-19 and looking at communities of color, particularly vulnerable communities. And one of the first things I started reading going into the literature is that there are these issues around distrust within the healthcare system. That is a major, major thing. This is also true for the mental health community, that there are issues of distrust, of credibility for professionals. And a lot of times my colleagues are confused by that. They don't understand how that could be or why it is. And so I like to present this slide, a few historical reasons why people of color tend to distrust mainstream systems. So there are reasons for that. There are empirical reasons why communities of color are very distrustful of systems in general. So let's start with Ma'afa, which is known as the Black Holocaust, in which millions of African people were killed, being brought over to the New World, to the Americas for servitude. And the horrors of that, of the transatlantic slave trade, and doesn't include the whole periods of slavery and then what happened thereafter. Second, we think about psychological hegemony, and that is looking at the Eurocentrism that you heard Dr. Barriell mention, the Eurocentrism in our training. So our training has not caught up to our social justice sensibilities. So when we look at our textbooks, when we look at the curriculum, when we look at syllabi that we use for training, it has not been updated. Everything is still very much based upon Eurocentric norms. So for instance, when I talk about the use of culture-centered theory in mental health, I ask how many people have received training in the area of African-centered counseling and in indigenous or indigenous ways of knowing IWOC counseling. You know, how many people understand the foundations of Latinx counseling theory and so on. And people say, no, they haven't been introduced to that. So how is it we can go through our training, graduate, get licensed, and practice and not know anything about the work that we want to do from a non-Eurocentric or non-Western perspective? And so that is the psychological hegemony of not thinking that to be mentally healthy may not be universal, that those things are centered on the values of that particular community. The third is racism in research. So, so there's so many examples. I'm a little overwhelmed actually in thinking about it. But the ones that I think about that come to mind have to do with like IQ testing that started back at the turn of the 20th century out at Stanford University in California, where they were conducting studies and had an all-white sample and then made inferences about intelligence for people of color. And then we can talk about the Trail of Tears in the US, residential schools in Canada, and the experiences of Indigenous people in Canada and the US in particular, and how people, their culture was literally erased so that people had their names changed, their physical appearances changed, they were removed hundreds of miles away from their homelands. They were not allowed to use their native languages and so on. And then in the US, the internment of Japanese Americans during World War II, and the removal of Mexicans from their homelands. I always say, when you move the border, does that make them an alien? I say, no, it does not. And so we have these experiences of people of color in the US, in the Americas, that make them very hesitant to be able to approach systems. So I like to talk about continuous traumatic stress as a framework for talking about transgenerational trauma and how it differs. So you've heard Dr. Barriell talk about traumatic stress as being very different from our previous understanding of trauma, where we're talking about trauma in the past, not in the present and the future. So I love this. This comes out of Frankel Schwartz and I think it's Banches in 2008, beautiful, beautiful article in which they articulate this, and I've been sharing it everywhere. So one, it acknowledges that the environment is pathological. So we heard Dr. Barriell talk about that of, we've been looking at the intrapsychic, the individual, and the individual's responsibility and how the individual could be pathological. And instead, what we need to do is to incorporate also a view of the environment and to understand that many times our patients are swimming in the pathology of systemic oppression, racism in particular. Second, it focuses on the present and the future rather than the past. So the issue is that we need to arm people. We know that they're experiencing oppression in the present, and they will experience it in the future. We're not going to eradicate racism tomorrow. We're not going to eradicate it in the lives of the people who exist today. That it's going to take time to do that over several generations, even while we're working very diligently to eliminate it. We still need to arm people on how they can maintain their mental health while they're in this environment. So we recognize it's happening now, but it's going to happen in the future, and that we need to really prepare them for that. Third, it observes that the trauma is unpredictable and sudden. So one of the things that we know about systemic oppression is that it can happen anywhere at any time. And so there is this anticipatory anxiety about it. Until many people of color will say, they just wonder, it's like clockwork. If they're talking to a mainstream person, if they're talking to someone of European descent, a European American, it's just a matter of time in that conversation that they either implicit bias, or explicitly with a microaggression, say something that is offensive, say something that is hurtful, say something that is racist, but you don't know when it's going to happen. It can happen over a phone conversation, calling for customer service. And they might say something, for instance, with a name that definitely represents that I am of African descent, I will often get that even before people see me, they will have a reaction to my name and be able to respond to it. And I might get microaggressions that way. Sometimes it can happen when you're at the supermarket and you're checking out. You might get a particular response. It's been recorded in research studies that people of color often get their change given to them on the counter, not in their hand, and so on. And so there are these things. I would even suggest that because of our past experiences, that even when we don't have these kinds of microaggressive exchanges, that we think about them and anticipate them, even if they don't happen. And so therefore we are negatively impacted, even in anticipation that it might happen. These are mental gymnastics that mainstream people don't have to go through. And so there's that element of unpredictability and the suddenness of it. And finally, it acknowledges that the trauma occurs with impunity through institutional means. And so that means that, of what you heard Dr. Barriell talk about controlling and having the power to be able to change things. And so oftentimes when we confront systems, when we confront individuals in systems and let them know how we feel about something, or we're commenting on something that they've said that has been offensive, that they have the power to, be able, if it's a physician and it's an appointment, all of a sudden we're having difficulty making an appointment, or we're not getting our lab results back, or they might just drop us altogether in that. So it's important to understand that certainly when we take a look at police brutality in the US, that is a clear example of the impunity, that we have people who enforce the disparity rather than work toward minimizing it. I wanted to include something about early childhood because, when we talk about maternal health, we're also talking about mothers, and therefore we're talking about their babies. And so we need to be able to allow mothers to understand how our children are experiencing intergenerational trauma in the womb and at birth and thereafter. And a lot of times we look at infants and toddlers and we think that there's something special or unique and they're not human, meaning they're not experiencing the trauma the way that we are. And I say to you, the research says, no, they're experiencing it as human beings. They're just little human beings. So their capacity to talk about it may be compromised by their developmental age. But what they're experiencing is the same. I know when I developed a program called the Children's Crisis Unit, and I created a lab where we actually did assessment and interventions with children from birth through the age of 5 who were referred to us for allegations of sexual abuse. One of the things I trained my staff to do was to be able to interpret ways in which infants and babies are communicating to you that they're experiencing distress. And that distress can be as severe as it is for adults. So we don't discount babies. We don't discount them in the womb. Instead, we acquire the skills to be able to assess and intervene at whatever stage they're in. So when we look at children who often, and there's a relationship between traumatic stress and attachment. that we see inconsolable crying, a disorientation, diminished interest in their environment. Definitely we see the aggression, biting often is one of the things, hitting and so on, withdrawal, so we get that emotional constriction, and we get the disruption of thoughts and feelings that make it difficult for them to have and enjoy their normal activities. And so it's important for us to think about not just the mothers, but mothers through the process, right? As they go through that process, and also parents, mothers' ability to be able to assess what's going on with their children. So let's talk specifically about people of color in general. So again, we're continuing this discussion about the historical context. So we have a long history of racism and colonialism, and it really lends itself, it informs the distrust that we often have toward white professionals, white peers, and so on. Also, due to our exposure, right, to racism, oppression, and the subsequent environmental stressors, right? So there is this additive effect. It's like phyllo dough. It's layer upon layer upon layer upon layer that they're experiencing. And so we get that psychological distress. I also want to mention, although we haven't really talked about it, that people of color is still here and they're still producing, right? They're here today as part of this panel, right? So you're here. So we know that there's also resilience. We talk about transgenerational trauma. We also need to talk about transgenerational resilience, right? And understanding that although these things have happened to us in the past, to our ancestors, to our parents, to ourselves, and to our children, that we know that we are also coping with it. Some of those coping mechanisms are maladaptive, that's true. But we also have a lot of coping skills that have been handed down to us that work, and that we need to be able to package those things. If we could ever really concentrate on culture-centered interventions, that becomes important for us to talk about, right? And be able to do that. So I want you to reflect on that right now as I'm talking about intergenerational trauma, but also intergenerational resilience. And if you feel comfortable, I'd like you to put in the chat, what do you consider to be transgenerational resilience for people of color? If you could just, even if it's just one word from your own lived experience of your family and what you know that's been passed down to you in terms of coping and resilience, that you would be here today, that you would be a professional working in your right mind, despite all the things that have happened to people of color. If you could just share that. If you've seen it in the people you work with, what have you seen as ways in which they persist, they still stand, they're still there? And we need to see people in their totality. They have trauma that they're experiencing, but they also have resilience. And we need to focus on that, concentrate on that, expand and build on that, educate other people about how communities of color are resilient, despite all of these stressors that they're experiencing. Finally, there's an issue because oftentimes race and class get placed together. There's a confluence of that. And we hardly ever get to talk about the more affluent BIPOC individuals because we are not immune to continuous traumatic stress. I would say in some cases, it's worse because we're navigating within these white environments where we're experiencing the microaggressions, right? And we're also trying to maintain our connection to our community, right? So we're experiencing it on a multitude of levels. And so it's important for us to recognize that we're not just talking about BIPOC communities where they're low income. We're talking about the full experience, right? So let's talk about traumatic stress, BIPOC, and women, right? So Black, Indigenous, and women of color, girls of color, may have some unique responses to traumatic stress, to intergenerational trauma. And a lot of that has to do with our complex identities, right? So we are often positioned within society as being less than because we're women, less than, right, because we're a person of color. Certainly those folks who are LGBTQ plus, right, are also experiencing marginality, right? Imagine that combination, right? And also issues of classism if they're coming from low income communities or histories and so on in families. So we have all of those things that we may be navigating, any combination of that we're navigating. And so one would naturally think that how we experience traumatic stress, how we experience intergenerational trauma would be quite unique, and that we need to really think about that, investigate that, and be able to respond to that. So one of the things that I recently learned, I did a webinar looking at suicide prevention. And I was focusing in on youth, on Black youth in particular. And in reading the current literature, one of the things that alarmed me was looking at Black girls, Black school-age girls, right? That the rates of suicidal ideation and behaviors were 3 times that of their peers. So we already know that this is one of the major issues for youth, just period, across all ethnic groups, SES, gender, that suicidal ideation and behaviors is a major, major concern. And it was already occurring. Suicidal completion rates were doubling every 10 years before COVID, right? So we know that this is an issue. But even with that being a general issue for youth, when I looked across gender and across culture and ethnicity, Black girls' suicide completion rates were triple that of their peers. So we need to take a look at that and try to understand better, perhaps, of the relationship between intersectionality of identity and some of the psychological distress that BIPOC women and girls may be experiencing. So resilience, it's so important that we talk about resilience, this ability to bounce back after experiencing some significant crisis or adversity and so on. But we need to investigate it within a cultural context when we're thinking about people of color, right? So we need to really think about what is it, right? So when we think about some of the things that you have mentioned here in terms of collaboration. So Janelle's talking about that in terms of being very community oriented. And what we know, right, about the recent work in neuroscience, right, and plasticity, right, neuroplasticity, of understanding relationships, right, and the importance of relationships in human mental health and how important that is. I love Nicole offering the use of elders and how we have historical knowledge, right? That what we know in the present and focusing on the present, that what's happening here for me is the most important thing, is a very Eurocentric concept, right? When we look at other cultures, we understand that wisdom, history, and elders are our most important and valuable asset as we try to confront problems today and in the future. And we need to do that. I love what Laura said about all life mindset. Absolutely. We have the spirit of Ubuntu, U-B-U-N-T-U, Ubuntu, coming from South Africa, right? Of this concept that I am because we are. So there is no me, there's no I, there is not this individualism, but there's this idea that we are connected to all things. We're connected to each other. We are connected to all living beings. And so therefore it's important. And that sort of takes us to other things about like why people of color should be concerned about the planet, you know, and things like that, because we recognize that we are connected. So I'm going to offer to you 5 social justice strategies and then leave time for you all to ask some questions or even make comments about what it is that we've been talking about, because we want to make sure that one, you understand and hear what it is that we're saying, and 2, if you're interested, you're clear about how you can move forward and do something different with the people that you work with right now, today, right? The work that you do, we want you to be able to apply it if that's what you would like to do. So 5 social justice strategies, right? Deep listening, social action, being strength-based, and taking an epistemic perspective on the interventions. And then the 5th one is, I'm cheating, a bunch more interventions, right? So take social action. So it's important that we look at the environmental factors, we look at external factors, and we try to remove structural barriers. So I often say to my students in counseling about why social action is so important. And I give the example, if you're walking down the street and all of a sudden lightning hits a tree and a branch falls on the person that's walking in front of you, and it's so big, it pins them down, right? We would not walk over to them, lean down and say, can you tell me more about that? So we don't want to talk through that. The first thing we need to do is what? Get that branch off the person. That's social action. So before we even get to what's your responsibility, how do you see this? What other actions might you take? Before we can get to that with our clients, and we heard Dr. Barriell talk about all these different things that are impacting people, what their needs might be, right? We have to stop and remove those structural barriers. We need to work toward removing the structural barriers and not solely keep fixing people and sending them back into pathological environments. Second, that we need to increase our knowledge about cultural practices. Why? Because we know that it's expedient for us to work within their own reality. Why should I teach them about how to cope, how to be resilient, when they probably already have examples within their own context of what their parents have done, or even people in their community have done, how their community has solved that problem in the past. And so we need to think about that and draw upon these cultural narratives and establish alliances with these families. Epistemic social justice interventions have to do with systemic structural change. So we need to think about how we can engage those of us in the academic area doing research. So I talk a lot about my work of emancipatory research methods, right? And those methods include collaborating with community stakeholders as partners in the research. So they come in at the very beginning and help to conceptualize the research, and they're there throughout the whole thing, definitely at the point of interpreting the research, because we need to have it as close to their reality as possible. So we need to collaborate with practitioners, with community people, with students, et cetera. People who are teaching in the classroom, whether it's K-12 or it's higher education, whatever, get out of the classroom, so that students can really see the problems in action and let them think critically about how they're going to deal with it. And definitely we need to be earth-oriented. Engage scholarship, the kind of research we need to do. We need to be working across disciplines, real world problems, and then that extra, definitely engaging in historical trauma conversations, use of rite of passage programs, and then of course, restorative justice programs. And I end with a quote from the late Senator John Lewis: never, ever be afraid to make some noise and get in good trouble, necessary trouble. Thank you.
Ooh, that was just excellent, and that does not even seem befitting. Grateful for us to be able to have this dialogue with you, the dialogue that is about to happen, right? We thank you so much, Dr. West-Olatunji, Dr. Lauren Barriell. It is great to have you here. I'm going to transition to Zora, as she will lead our Q&A session.
Yes, powerful presentation. Thank you, Dr. West-Olatunji and Dr. Barriell as well. So if you guys could just put any questions you might have, any comments into the chat, and I can read them off. We'll start out with this question. So for either one of you, why is self-efficacy and advocacy not enough for Black pregnant people and families?
Well, as I mentioned earlier, there are systems in place that will subvert whatever effort you put forward. There are prevailing stereotypes that people have, and I think a lot of people really don't realize they have. It is present in all of the medical books and all the training that we do, and just the way we talk to people. And so self-efficacy is great, you know, and I encourage people to advocate for themselves, you know, their family members to advocate for them. I even advocate for them. But if we're not going to have any change until we change the system. And here's the thing, and Dr. West-Olatunji, you alluded to this earlier, and that is that we perceive ourselves as being the only recipients of this, you know, oppression and racism. No, I, as a physician, when I go in every day, I have colleagues who, yes, express racist ideas. And I have to contend with that on a day. Now I call them on it, I do. But it's not enough for one little lonely voice in the wind to change the system.
Yeah, absolutely. So that's that bootstrap theory, which is just a ruse. Don't pay attention to the man behind the curtain. It's like, that's a ruse, right? So it's the bootstrap theory, but the issue is that the system is stealing our bootstraps. We don't have any straps. We're wearing shoes with no shoelaces, and they're telling us to lift ourselves up by the shoelaces. That's what that's saying. But they took them, right? Now, it's true, all right? I know about making a way out of no way, all right? I know we do it, but that's not a way of life, right? We need to confront them. So sometimes we can get into the habit of not expecting to have those shoelaces, and we live like that and work around it. We bend and we do this and we're that and we're resilient. But we have to remind people we're doing that because of these external forces. So we can do that in the meantime, but that is not the agenda. The agenda is to make sure that we have the resources that we need to live abundantly. And that's what we're fighting for. That is what we're advocating for. And so we don't want to accept that. We don't want to accept this idea that we need to pull ourselves up from our bootstraps. Second, that's not even happening for the majority. This business of the bootstraps, not at all. Kimberly Crenshaw, who's a lawyer out in California, has a great video that's on YouTube that exemplifies, you can see it visually, about this issue of the privileges that are given to folks in the mainstream. They're not being pulled by their they're not pulling themselves up by their bootstraps either. So that's why it's a myth. It's an urban legend. It's not true. Nobody's doing that, but they're expecting that we would do it, and we don't have any bootstraps. So we need to learn to first recognize our marginality. And that's the work I mentioned at the end about having the opportunity to have these conversations about traumatic stress. We need to, what's called a hard reset, right? And there's a book, I'll find the name of the book, that talks about the hard reset that's needed, because we're so used to the Eurocentrism and the Eurocentric ethos and way of thinking that our words are not our own, our minds are not our own. We don't even have our own thoughts. So it's work. We got work to do to try to get back into our own minds in order to come up with solutions. But the first thing is recognizing that it's not possible for us to do that. And we shouldn't have to do that. And we need to advocate against it.
Exactly. Yep. And Janelle said yes, too. I think there's a lot of people agreed with that answer. Thank you. Are there any questions? Again, if you guys have any more questions, please put them in the chat and I'll be watching that. The next question that I have is, what role does epigenetics play in transgenerational trauma? So I think you guys kind of talked about that in the beginning, but.
And I wanted to include a little section about this when Dr. West-Olatunji and I were talking about doing the webinar, but we just didn't have enough time. We were just saying there's like 50 slides that could have been put in this whole presentation, but when you think about the way the human organism is made, it was created to survive. And in order to do that, it has to evolve. How does that evolution take place? It is a response to a stimulus, and then the DNA changes, right? Mm-hmm. And that DNA change usually is something that benefits the organism, that assures ongoing success. I'll give you an example. A lot of people have heard of sickle cell disease. And what that is an evolutionary response to an infection, to malaria. So people who have sickle cell disease do not get malaria because the cells sickle and the organism dies. They live, the organism dies. And so, but that ultimately, now that we've developed antibiotics and the like, we don't necessarily need to have that evolutionary thing going on, but it's still here. But that is how the human organism works. And just like we respond to the malaria organism, human beings respond to the ongoing stress from minute to minute, day to day, through the response of their hormones. Those hormones have effects on the entire body, not just the parts you can see, the parts you can't see, and it affects DNA. And so DNA is in a constant state of evolution. And so going forward, we can look at things like maternal mitochondrial DNA and see multiple generations back where that came from her mother and her mother and her mother. And so that kind of research going forward will be very valuable in helping us to determine what it is we need to be targeting to reduce oxidative stress and, negative health outcomes as a result.
Mm-hmm. Let me also add that it's not deterministic. So, and it's important to mention that's not what the neuroscientists mean. So the idea is that with the human beings can make anything happen. That's important. Mm-hmm. And that we can mutate this way and mutate that way, same person, right? Mm-hmm. So the idea is not to take this research and say, well, people of color just lost. That is not what we're saying. What we're saying is that we need to do things that impact that what's known as the allostatic load, and that we need to be engaged in work, reaching out to people involved, doing what I saw in there about, the power of women working together, mm-hmm. And how that feels. And it's like, how does that change things? So how do we do that? And we've seen it happen in our communities. Just to pull up a name, we think about, Malcolm X. Malcolm X, in a deterministic perspective, we would have thrown him away and said, all is lost, mm-hmm. right? And then he turns out to be one of the greatest leaders of all time, to put us in our right minds, to give us integrity, to give us a voice, to give us courage, to be able to speak up. So it is not, so I like to emphasize that. We do not mean that it's fatalistic and deterministic. So once you find out that, then you just throw away all people of color, all children of color. No, you do not. Anything can happen. Yeah. And that we need to be working toward that change.
That's a great point. And that comes up when talking about like ACEs as well, I think too. Sometimes when people look at those studies, they're like, oh, you're doomed if you have ACEs. And it's like, no. So great point.
I'm gonna give you one word for that. It's
Yeah.
called pluripotent.
Can you say that one more time?
Pluripotent. That means you have the power to be anything,
I love that.
multiple things, and it's just determined by force of will. That's it.
I'm gonna write that down. Thank you. And I'm not seeing any more questions, and it does look like we're kind of getting towards the end of time. So I will pass it back to Nicole. But again, thank you, Dr. West-Olatunji and Dr. Barriell as well.
Yes, what an amazing dialogue. And it is our hope that we all have gained some new wisdom and resources to bring back to our community. I think the most value for me is always give me a challenge, give me a charge. What am I to take back to my community? So those action steps are really great to be able to share, and that will live here so that we can refer to them as we are directed in our work by wisdom, research, and best practices. So we thank you both so very, very much for sharing your time with us. And we thank our sponsors, and we thank Wayside. And I believe this is a beginning of a beautiful conversation that will continue to connect our communities. So thank you so very much, and have a wonderful afternoon. And everyone who participated today, we hope that you will join us for our next session, which will be Mr. Calvin Williams. Again, he will be talking about fathers are not born, they are made, and he has many years of working in the community. So I hope you will join us for that, and that information is placed in the chat. Yes, you can have access to the recording. You will receive a survey and information in the next 24 to 48 hours. Have a wonderful afternoon, everyone, and thank you again. Be well.
So much.